Welcome to Deuk Spine Institute. We're streaming live. It is July 2nd, 2024. Our patient is having back pain. He's had extensive fusion surgery. As you can see, he's got even a broken screw. We did not do his fusion surgery. It was done elsewhere. AP. But he has a disc below the fusion called adjacent segment disease that's now damaged and causing back pain. So he has to have surgery now done at the disc below the fusion. We call that adjacent segment disease. Shot. The first thing I need to do to fix his L5-S1 disc is to get into the disc, which requires placing a needle in his back, in this case 2, because we're going on both sides. I think you're off on orbit just a little bit. I can tell you there's a massive amount of scar tissue. I feel it. I think that's better. We're using our X-ray machine to navigate. I need an AP view. Machine for two purposes, localizing and navigating. Localizing means finding our target. Navigating means getting to where we need to go. Perfect. All right, you can see the broken screw at L5. It's on the left side. He has extensive fusion. If I had to venture a guess as to why the screw broke, I would say he's number one, a big guy, but also you could see there's no cross links placed by the surgeon. Without cross links, the construct is lacking in certain types of structural support, AP. And without cross links, you can fracture screws. So they should have put cross links. They also should have put a cage. Without anterior column support, aka a cage, you're going to fracture the screw as well. So the surgeon who did his fusion, I think, did a very bad job. Technically, they didn't put cages and they didn't put cross links. And I think that's why the hardware has failed. All right, we are ready for him to be awake. How long do you think? What's going on here? Can you pull this down, please? You're not supposed. It's not supposed to be. Are you paying attention? All the way down. How long has he had back pain for? 30 years. You think he's ready to go?
How are you? You okay? Don't move. We're going to ask you some questions.
Lay still.
Lay still. You're doing great.
All right, Henry. He's had back pain for 30 years. You could see he's had a scar on his back that goes from here all the way down to here. You guys see that scar?
Yes, we do.
From here to here. I did not do his fusion. He's from Idaho. I think he had his fusion done there. Idaho. Did I spell it right? Idaho. All right. Long story short, I don't believe the surgeon before did a good job. He didn't put cages, didn't give anterior column support. The discs are already bad, so they're collapsing. So it puts a lot more stress on the screws, which then can break. On top of that, there's no rotational support because there's no cross links. And it looks like he did an osteotomy, the surgeon did. So that's even worse. All right, we are ready to test his pain when he came here was right here. X marks the spot, pain. And he had tenderness in the facet joints on both sides. This is a facet, this is a facet, this is a disc. That's the L5-S1 disc. Are you guys ready? Dr. B?
How you doing, my friend? We're going to ask you some questions, all right? You okay?
All right. Shot?
Give us a pain score, 0 to 10, my friend. What number would you give us?
take this. Maybe we can time the anesthesia a little better. We need it when I come in and start poking them and wear off by the time we're ready. Shot. We're going to fix the L5-S1 on the left side first. Shot. You can see the hardware makes this difficult for me. It creates a lot of scar tissue, which I'm feeling right now, and it creates a more difficult trajectory and path to get to the disc. It's just solid scar tissue I'm feeling. All right, we'll advance the dilator down to the disc. Shot. Wow, just incredible. So different than somebody who hasn't had such extensive back surgery, you know?
Sam, where are you? Stay there.
You ready, Dr. B? Yep. All right, let's. Really don't like doing surgery on somebody who's had so much surgery already, but the truth is, without this procedure, he's destined to have pain the rest of his life, and I don't want him suffering. We really want to help him. Hopefully get him out of pain. Shot? All right, that looks pretty good. We're inside the disc. What we're going to do now is we're going to repair this disc. Now, Henry, let's show the audience why is it that a disc injury can cause so much back pain.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals.
You can see on the video where the pain comes from. It comes from this pink inflammation tissue in the back of the disc around the tear where the herniation is. And that's what we're looking at right now. That is the pinkish red stuff that I'm trying to remove here with our grabber. Now, if you have a question, feel free to type it up, ask your question. I'll do my best to answer it for you while we're streaming. We are streaming live surgery. We're the only place in the world that does this on a regular basis. We stream our spine surgeries live every week. Every single spine surgery we do, we stream live. We do this because we want to teach the world about spine surgery, and I can answer questions for people about spine problems while I'm operating. We have a lot to share. Now, we also do it with patients' consent. Sometimes the patients don't want their surgery streamed. That's fine. We don't stream it. But today we're doing actually 7 surgeries, 2 of which have already completed, and they were not live streamed, but this is our first live stream. It's surgery number 3 for today. If you have questions, feel free to ask. There's no questions, Henry. Let's show the audience how this laser I'm using right here to clean up the tear, how this gets rid of back pain.
We do have a question, but we can come back after this educational video.
Sure.
Copy that.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
And you can see from our video animation that what we're doing here is cleaning out the tear in the back of the disc where the pain comes from. It was discovered at Deuk Spine Institute by myself 18 years ago that the pain that people get in their back, chronic back pain, comes from a tear in the back of the disc. You're looking at that tear right now through this tube, and by taking a laser and cleaning the tear, we can actually eliminate back pain from the disc that's causing it. Now, this surgery doesn't fix all back pain, of course. It only fixes back pain from a disc called discogenic back pain. It won't fix pain from a piriformis muscle or a sacroiliac joint. That has to be dealt with separately. But the most common cause of back pain is an injured disc, and it's inflammation within the injured disc that causes it. Let's take our first question of the day.
First question coming from Lanu on YouTube,
Lanu, welcome.
asking, what are the chances of a herniated disc that leads to nerve damage?
Nobody knows the chances of a herniated disc leading to nerve damage, Lanu. If you have a larger herniation, you're going to have a higher chance of nerve damage. Smaller herniation, less chance. If you have congenital spinal stenosis in the patient, that means they already have narrow holes where the nerves come out, higher chance of nerve damage with smaller herniations. If you have facet arthropathy, higher chance of nerve damage. Larger herniation, higher chance of nerve damage. But other than that, it's no way to predict who's going to have nerve damage from a herniated disc. Good question. Any more questions from our audience?
No current questions, but we do have a comment from Jason on YouTube saying, gonna get you my diagnostics and reports, doc. Thank God I didn't do the ACDF.
Yeah, thank God you didn't, Jason. You are correct. By the way, I like your name. It's just my middle name, Jason. Somebody wants attention. All right. Yeah, so we have a free MRI review, Jason. Costs you nothing. All you got to do is upload your report and your image. Your images, it's called DICOM image set. It's on a CD, or if you have a portal that we could use from the MRI center, if you send us your login credentials and the link, we can actually pull the images down from that site, have them ready to go for the MRI review. My MRI review team is phenomenal. Sam heads up that team. Lily also works on that team. And they actually do a great job of providing me with your history, which you put on the website when you fill out the form, as well as your images and reports. Once I have the history, the images, the reports, we schedule a 10-minute virtual Zoom meeting, and during that meeting I can talk to you and make a diagnosis as to what's wrong. Now, you may already know what's wrong because you have an ACDF scheduled, but oftentimes I find that what other doctors are recommending is not necessary, or it's the wrong areas or disc. So it's good that you're getting a second opinion for free from a neurosurgeon like me with lots of experience. I've done 1,000 ACDFs in my career. 1,000, that's a lot. And this surgery the Deuk laser disc repair is going to replace at least 90% of ACDFs, especially the ones done for degenerative conditions like disc injuries. Now, the Deuk laser disc repair cannot fix OPLL, which is ossification of the posterior longitudinal ligament, or spinal fractures that are unstable. Those still need to be fused, but the vast majority of spinal fusions done today are being done for degenerative conditions like disc herniation or disc bulge or disc degeneration, and spinal stenosis, radiculopathy, myelopathy, and all those can be treated with the Deuk laser disc repair. So you don't need to have the fusion done. Why aren't more doctors doing it? Lots of reasons. The first, they may not even know about this technology. It's so new. Second, they make a lot of money doing fusion, so why do something like this that pays a lot less to the surgeon? After all, it's the surgeon who recommends the treatment, right? So they're going to recommend the most lucrative treatment for them. Unfortunately, that's what they do. They're not going to recommend the best treatment for the patient. There was a time when that's what doctors did. They recommended the best treatment for the patient. But unfortunately, many doctors these days no longer are really in it for themselves. And so they're going to do what makes them the most money. Also, we have outside forces. For example, the companies that manufacture the metal implants, or the stimulators, or the cages, everything that we put into a fusion, those companies are heavily lobbying and promoting their products to surgeons. As a matter of fact, they've infiltrated the educational system for surgeons at the universities. There are 120 neurosurgery training programs in the United States, and all 120 have some affiliation with some company that makes metal that goes in your spine. And those companies pay money to the Department of Neurosurgery in the form of research grants and support that pays bills for those departments. And quite honestly, the reimbursements for fusions are very high. They're the highest of any type of surgery of the spine. So spinal fusion is being recommended around the country at alarming rates because, well, it's lucrative financially for everybody involved, the hospital, the surgeon, and the implant companies. Those are the decision makers. The patient ultimately makes the decision, but if they're not aware of the motivation by their surgeon or the hospital to do more extensive invasive surgery, they're not going to be able to make an informed decision, basically. And I'm glad you are making an informed decision, Jason. That makes me happy. It means I've done a good job of educating you. What we're seeing here is fat and a little bit of blood vessels, but we are at the back of this disc on the left side, 5-1, and we are inside the tear. You saw that I cleaned the tear with the laser. That is the Deuk laser disc repair. It's pioneered and invented here at Deuk Spine by me, the founder. 18 years ago, we did our first Deuk laser disc repair. This month, either June or July, 18 years ago. So we're just reached our 18-year anniversary for this procedure. We've been doing it for 18 years. It's been peer-reviewed and published multiple times in the medical literature. The first study we published was almost 13 years ago. And we've been doing this procedure for 18 years, outpatient. We've never had a serious complication from the surgery itself, ever. And it's very safe. I've done over 2,000 of these procedures now. We're getting ready to launch our new website, which Henry has been involved with, along with Sanjay and our team in Europe, designing the site. It will be an incredible educational opportunity to learn about back pain, neck pain, and honestly everything that I've learned from my patients and my treatments over the years. And it's going to be completely revolutionary. You won't find this information anywhere else because other doctors don't know about it. So I've given up on trying to teach the doctors. I'm teaching the patients. So that's why we broadcast. That's why we answer questions. Any other questions from our audience?
Yes, we have a couple questions. Next one coming from Lanu once more on YouTube.
By the way, before I take Lanu's question, you see all this white stuff? That's scar tissue. And this stuff that I'm hitting with the laser right now, that's herniation with scar tissue around it. This is really firm, very hard. It's like hard rubber. And it's pushing right on the nerve. And that's why the nerve root that it's pushing on is going to be the L5 nerve root and the S1 nerve root. And those nerve roots get pushed on or irritated by this firm, hard mass crushing them, and it causes weakness, numbness, tingling in the legs, or even leg pain called sciatica. But that's not what causes the back pain. The back pain comes from inflammation in the posterior annulus. That's what I'm cleaning out right now. All right, we'll take Lanu's question.
Lanu on YouTube once more asking, watching you vaporizing pieces of herniation is fun.
Yeah.
Have you ever think about creating a video game that vaporizes pieces?
You know, it's so funny you say that. No, I haven't thought about a video game, but it reminds me of video games. And I used to play a lot. But you know what else I was thinking about, Lanu? Is, you know how there are these videos on YouTube that people love to watch, like food being made in a factory, or, you know, people like doing things that are repetitive, and it's just mesmerizing and calming? We should do one of those, like a looped video. All right, I'm pulling out pieces of herniation because vaporizing them with the laser is wonderful, but sometimes the herniation pieces are pretty big, and you know, the best way to deal with them is to pull them out, not vaporize them. But sometimes they're scarred to the annulus. You have to vaporize them or they won't come out. These are all pieces of herniation that are stuck within the annular tear. And like I said, you know, the surgery is a combination of using the grabber plus the laser. It's not just one or the other. It is called the Deuk laser disc repair. However, we do use grabbers as well. That's a nice chunk. Just about done here, and then I'm going to move on to the other side. Now this patient happens to have facet joint pain as well. So we will end this broadcast, and when we're done with both discs, both sides of this disc, sorry, not both discs, but one disc, both sides, and we will do facet joint Deuk plasma rhizotomy. Just about done with this side, another minute and we'll be done. I've already placed the needle on the other side, so all I really need to do is walk over to the patient's right side and do the other side of this disc. This is the L5-S1. Ooh, I think I grabbed the needle on the other side there. It's in there somewhere. Might be able to see the needle on the other side, but we want to avoid melting it with the laser. You know, I love doing these surgeries because they help the patient so much. Oh, he doesn't like that. Yeah. Because this is the painful part of the herniation right here. And I'm zapping it away, getting rid of the pain, but that's where all the pain nerves are. They've grown in this area. Yeah. Yeah. Yeah, we're almost done here, but we are in the most sensitive area. And we do put numbing medicine in the disc. When we do our discogram, it's kind of nice, it helps, but it's certainly not enough. This disc becomes so painful in these patients that you really have to anesthetize them to get them comfortable. That's why we do it under anesthesia. Really isn't the placement of the tube and needle that's so bad. It's vaporizing this painful area of the disc. This is really what bothers most patients. You see the vein right there?
Yes, we do.
Now it is in my way, so I'm going to have to probably take it. We call it taking it when we're doing surgery. And we have to cut something, okay? So I do that on purpose when I have to, because if I don't, I can't finish the surgery. 30 seconds and we'll be done. That looks good. I think I've cleaned out the painful tissue and he's going to heal beautifully. You see the laser is good at hemostasis as well. It can actually stop bleeding in a vein when you cut it. All right. We're done here. Just cleaning up lateral. Any other questions, Henry?
Yes, we have a couple more questions. This next one is a comment coming from Joanna on YouTube
Hi, Joanna. Welcome to our stream.
saying, I can't stop watching this. This is so interesting. I suffer from adhesive arachnoiditis.
Arachnoiditis? Sure.
Arachnoid.
Well, Joanna, you may actually be fixable at Deuk Spine. We just need to do an MRI review with you. Adhesive arachnoiditis never causes back pain, ever. It causes only numbness, tingling, and sometimes weakness in the legs. So it's really only causing leg symptoms. So if you have back pain, it's not coming from your adhesive arachnoiditis. I promise you that. And it's totally fixable. So I'd love to do an MRI review for you for free. Just use our link that Henry will put here on the site. And I'll give you 10 minutes of my time for free and hopefully make a diagnosis for you. If it is adhesive arachnoiditis that's causing your leg symptoms, then the best treatment, unfortunately, today is what's called a spinal cord stimulator. Spinal cord stimulators can be very helpful, but you need to do a trial stimulator. But you would be an example of somebody who actually really would benefit from a spinal cord stimulator, which is really the only treatment that I know of for adhesive arachnoiditis, besides a morphine pump, which I wouldn't recommend. They're far less effective. Intrathecal pump. Thanks for the comment. How's it going, Davis? We're going to do this side at 5-1 on the right, and then we're going to end the broadcast, and we've already numbed up the skin earlier. We're going to end the broadcast and do the facet joints at 5-1. We'll start a new broadcast for that. The whole surgery is done through a 7mm incision. Putting pressure on the other side, good. All right, so we're going to take this needle out. We've got the guide wire in, and I'm going to bring the dilator down with some numbing medicine. Huh? Any questions?
Yes, this next question is coming from Celeste
Thank you.
on YouTube
Yes, Celeste.
saying, hello, doctor. Is it possible to have hip pain because of a herniated disc? Blessings, Celeste from South Africa.
Hi, Celeste. It is possible to have hip pain from a herniated disc, but it's uncommon. Most of the time, hip pain comes from other things. But again, I could tell you exactly what's causing your hip pain if you did a free MRI review. Look for the link on our dialog box. It says mri.deukspine.com. You will get a free 10-minute consultation with me. I will diagnose what's wrong with you, and I would be very surprised if it was actually your hip that was the cause of your pain. Very surprised. If it was a disc that was the cause of your hip pain. Very rare does the disc cause hip pain. Very rare. Less than 10% of the time. So there's a much higher chance you have sacroiliitis or piriformis syndrome or trochanteric bursitis or degenerative joint disease of the hip. Those are the most common causes of hip pain. And I could usually diagnose it very quickly on Zoom if you're interested. All right. We are now at the right side. Hold on, L5-S1. I need to aim down a little bit. Shot. Yeah, you see how I changed the aim? Hold on. I think that's good. Go ahead. Okay. The reason we did bilateral at 5-1 is he's having symptoms on both sides from nerve root compression. So I'm trying to decompress both foramen. I think that's good. Yeah, I'm fine. Got pieces of herniation all over the place. Let's show the audience this, Henry, real quick. I'm going to bring up this blue towel. Can you guys see this?
Yes, we can.
What you're seeing here is like probably 40 pieces of herniated disc that floated out when I was lasering. And the reason I'm showing that is because a lot of people think a herniated disc is one piece. It's not. It's always, always, always in multiple pieces. And our average is around 30 pieces per patient. The herniation. Okay? Think about that. That's a lot. But it's a misnomer. By the way, there's that pink inflammatory tissue. You guys see it?
Yes, we do.
The pink tissue that we showed you on the video earlier of that causes all the back pain? That's it. That pink tissue is where the nerves are that cause the back pain. That was discovered here by me, the founder of Deuk Spine Institute, 18 years ago. It wasn't taught to me in my residency. It's something I figured out by doing this surgery on people and watching their pain go away right after the surgery. And I realized that we weren't just unpinching the nerve root to fix their leg symptoms, but we're also curing their back pain, which is unheard of, you know. In spine surgery, curing back pain, nobody cures back pain, but we were curing it every single time with this surgery, which was originally done to fix pinched nerves, and fix leg symptoms. So I kind of stumbled on the discovery, but we've never had a patient where we didn't get rid of their disc pain, their back pain from the disc, their discogenic back pain, we call it. Any questions?
Yes, this next series of questions comes from Mixin' On Up on YouTube.
Mixin' On Up, welcome back.
First question asking, what reactions do you typically see the body make when you are in the most sensitive areas? Like the worst reaction you've seen a patient's body make?
Sure. So Mixin' On Up. Pain, there's an old saying, pain is in your head, right? And most of us kind of laugh it off, but there's some truth to that saying. And what it means is that the way that we feel pain as human beings is we get signals from parts of our body that are painful. We get those signals through what are called nerves. And there's three types of nerves: motor nerves, sensory nerves, and autonomic nerves. Okay? Autonomic nerves we're not going to talk about much because they go to your gut, your kidneys, your bladder, things like that. You don't really pay attention to those things. They're all reflex type nerves. But sensory nerves allow you to feel, okay? And sensory nerves transmit signals, like little electrical blips that come from a body part and travel up to the brain through a pathway, okay? Using your spinal cord and nerves. And these signals, when they get to your brain interprets them as being being painful. Now, there's two types of sensory signals. There's what are called somatic afferent and visceral afferent. And somatic afferent signals are special not because the nerve fibers are different. They're special because of where the signal ends in your brain. it ends in a part of your brain that is capable of localizing where the signal comes from. Okay? We call that part of your brain the primary somatosensory cortex. Primary somatosensory cortex. And if the signal didn't get to the primary somatosensory cortex, you wouldn't feel the pain. And that's the basis of spinal cord stimulators, is they're designed to short circuit the signals getting up to your brain. The problem is they don't work. And if they work, it's only temporary. So they're a horrible solution to the problem because they don't work. All right, they move, they stop working, the batteries run out, the generator stops working, the leads get scarred, and functionally they just stop working. But the idea of short-circuiting pain signals from reaching your brain by stimulating the, by basically short-circuiting and stimulating the spinal cord, it's a good idea, it just doesn't work. So what I'm getting at is the way we get so that patients don't feel the pain where I'm operating is we shut down that consciousness, the conscious part of your brain, with medicine. That's what anesthesia does, okay? Shuts down the brain so you're not aware of the pain. The pain signals still reach the cortex, but you're not consciously aware of it. You don't make an association to that signal, to what it means. Oh, my back hurts. So when the patient feels the pain and responds to it consciously or in a sleepy fashion, they're going to move their body. That's the response. That is a reflex type response that has been programmed into our bodies for millions of years, right? Through evolution. When something is painful, you move away from it. So if you're sleeping and somebody pokes your hand with a needle, you're going to, even though you're not consciously awake, you're going to pull your hand away. All right? And that's because that's how your brains are wired. And that's what we see sometimes, is that the patients aren't awake, but they're responding to the painful stimulation. And the way they respond, you asked, they wiggle their body, and they try to get away. They try to get away from what I'm doing. They just move their torso. So the way they do that is by flexing their hip and flexing their knee, and that moves their body. We don't want them moving, so we don't want that movement. It's not wanted. You don't want a patient moving and falling off the table. Now we have all of our patients strapped down real good, but big man who's strong may break the straps or move the straps and then fall. So we don't want that happening. Good question. Next question.
Next question from Mixing On Up, asking, what do you think the percentage is of patients you see where herniation has led to severe radiculopathy as opposed to back pain?
Yeah, the percentage of patients that have a herniated disc with radiculopathy and no back pain, I would say it's less than 1% of our patients. 99% of our patients have back pain along with their radiculopathy. It's far more common to have patients with back pain and no radiculopathy. Very common. Probably 25% of our patients have back pain with no radicular symptoms. Now we may find on examination that they have weakness, or we may do a nerve test and find they have radiculopathy on the nerve test, but we call it subclinical radiculopathy, meaning that it's not clinically present on the patient on exam or historically. So the patient's not really symptomatic, but it's still there because we know there's damage from the nerve test, which is a objective test running current through the nerves and checking to see how much diminution there is of the current downstream. Okay? But besides the nerve test, I would say 25% of the patients have back pain without radiculopathy symptoms, and I'd say less than 1% have radiculopathy without back pain. Next question.
Next question from Mixing On Up once more on YouTube, asking, could someone be confusing hip pain with an injury to the S1 or S2 nerve root?
It's not common for S1 or S2 to just cause hip pain, so I would say no. If you have an S1 or an S2 problem, then you're going to have symptoms down your leg, all the way to your toe. Usually at least with an S1. But the sacroiliac joint, the piriformis muscle, the trochanteric bursa, the arthritis in the hip, those are all, and of course, what do you call it? Anterior, the capsulitis. A torn labrum. That can also cause hip pain. So there's a lot of common causes of hip pain, and I can usually figure it out very quickly, whether somebody has a hip joint problem or another joint muscle around the hip. Good questions. Next question. All right, we're almost done. See all this hard scar tissue here, guys?
Yes, we do.
And it's caused by inflammation. His body reacting to the herniation that's sitting inside this tear. He's reacting to it. His body's attacking this herniation, trying to get rid of it, trying to make it go away. Kind of like your body attacks, you know what a pimple is, right? Pimple is really your body attacking some bacteria that's in the, hair follicle or sweat pore, and causing it to become red and swollen and painful. What is the chattering, Luis? Oh, it is. I know that for sure. But why is it? Yeah, I'm getting good flow. Just about done. There's the end of the disc. You guys see that? There's some more inflammatory tissue like a pimple. It's all hard. This is all, I could feel it. It's literally like if you took a stick of butter and froze it, that's what this feels like. Really hard. And if you took a hot knife and tried passing it through that frozen stick of butter, you'd feel some resistance, but you'd eventually get through it. That's kind of like what I'm experiencing. But this is the damaged part of the disc causing his back pain. He's had it for 30 years. And he even went and had a fusion on his back, and that didn't fix the problem. So here he is at Deuk Spine from Idaho, getting his fix. Questions?
Next question coming from Lanu once more on YouTube, asking, do you wear reading glasses when operating?
No, I don't wear reading glasses when operating. I don't know who would wear reading glasses. Maybe you've seen surgeons with glasses, special glasses. They're called loupes. They're magnifying glasses. They allow us to see areas way down, in front of us, a foot away, magnify them 2 or 3 times and be able to see things better. But I don't use them. No, I use a television screen to operate. And I'm looking at that television screen right now. And what's being projected on the TV screen is the image from the endoscope. So this is endoscopic surgery we're doing. And just like you're seeing down a little tube, I'm seeing the same thing you're seeing. But I see it on my TV screen and you see it on your TV screen or phone. I don't see it on a phone because I use a TV screen, a medical TV screen. All right, let's do grabber. I need about, another 30 seconds, or no, I'm sorry, 2 minutes, and we'll be done with this. We're going to end the stream. We're going to come back with Deuk plasma rhizotomy. This patient has facet pain as well.
Maybe put a piece of foam or something.
That was a nice piece of herniation that just came out. Any questions?
At this moment, no current questions.
All right. Take that. No, we're not done. No, there was just a piece of herniation blocking my view. Almost done.
Sorry.
Getting a little too jumpy. Have you heard the saying, jump in the gun? Anybody heard that saying, jump in the gun?
I have.
Let's see for somebody who doesn't know. What does it mean, jump in the gun? Anybody know? Huh? Anybody want to, besides Henry, who has access to the internet, anybody want to guess what jump in the gun means? The saying, the old saying? It does? What? Who says what? Is that, did you say track? You're correct. It is the gun used to start the race. And jumping the gun means the runner started the race ahead of everybody else and ahead of the gun, which you're not supposed to do. It's called jumping the gun. And if you do that, then, you know, you get away with it once, but after that, they disqualify you. You're supposed to start the race when everyone else does at the sound of the gun. The gun literally is held in the hand by the race official, who then says, on your marks, get set, and then boom, the gun trigger is pulled and a loud sound is made and everyone starts running. So basically the gun jumper is a cheater. Any other questions, Henry?
Yes, this next question, excuse me, coming from Jerome on Facebook,
Hello, Jerome.
asking, can cartilage regenerate?
Can cartilage regenerate? No, not usually. Unfortunately, cartilage has very little ability to regenerate naturally. Now, there are experiments happening right now in labs where they're trying to grow cartilage to put it back in people's joints, but that is not going to really help with the people's pain. Why? Because that's not the cause of their symptoms. 30 seconds. All right, Henry, we're going to have to end the broadcast.
Copy that.
And we'll come back in just a few minutes with our Deuk plasma rhizotomy, which is treating his facet joints on both sides, which are hurting him as well as the disc. So he had more than one cause of pain. He had the L5-S1 disc, and he had 2 facets, which gives him 3 total causes of back pain, 2 in 1. And I think I've gotten all the herniation out that I can get. There's one piece right there, and that should be it. All right. Good job. Let's end the broadcast. We'll be back shortly.
Copy that.